Happy Thursday, everybody. Welcome to yet another VMR. I'm very excited for many reasons today. It is the return to the humble scribing seat for our beloved Noah, and I can't tell you how much I admire that for him to be doing the core sit there and type skill, which I think is a real testament to what the space is about because it's about pushing yourself to in the intellectual uh, peaks of Mount Everest. And Mount Everest is on my mind because Shreya, who's from Nepal, is doing the teaching point. Um, but I really, really admire that, Noah. I wanted to thank you for doing that. I think it's such a powerful symbol of what CP Solvers is about. So contrary to the typical order of things, let's start by introducing our scribe and our teaching points people. So Mike to you, Noah, and then to you, Shreya, for anchoring this session.
Hey everyone, so happy to be here. I'm super excited for today's session. I heard we have super special case presenter.
Yes.
Right.
We do indeed. Shreya, how are you? Update us, please, on how life is treating you.
Hi everyone. I'm Shreya and I'm leading teaching points today. I'm pretty good. Just normally resumed my walk after coming back here. Yeah, listening to CPS on and off. And yeah, I'm really excited for what's coming.
Yeah, oh my gosh, we have two treats for you. The first is, I think, uh, it's not the first discussion, but the second discussion of I think somebody who's on the path to be a really outstanding clinician. Glenn and I have shared this space on Thursday, and you know it's him co-discussing since you've looked at the email. He's already co-discussed before, and when you're doing this twice, it's a marker of your tremendous growth. And if you know nothing about Glenn, I will tell you that he is, if he is not at one of the sessions learning behind the scenes, I worry about his health. He's such a dedicated learner and has contributed so much to this space. So kudos to you, Glenn, for all the growth that and effort that you're putting in, and we're very, very excited to put that to the test today. I'll hand you the mic to say hello, and then we'll finally introduce our new guest case presenter.
Hello everyone, and thank you, Ravi, for the kind words. Actually, I want to say thank you for this moment to be able to co-discuss with you to learn. Um, curious about how you. I want to learn how you always like approach any problem presentation. Like it's so amazing. Like, I want to get that skill right, but then it shows that you probably need more experience to reach uh, that level. So looking forward to learning from you today.
Hello, Dr. Rabi. I'm not sure if it's just me, but
Oh
we can't hear you.
no! Yes, I think. Oh my gosh, sorry. My apologies. I was bestowing a lot of love upon Glenn, which I will summarize to say that yes, Glenn, you're right. I think there's nothing that replaces experience, and I will tell you that by the time you have as much experience as I have, you will dwarf my clinical reasoning abilities because the efforts that you're putting in are absolutely incredible. Thank you, Saketh, for jolting me back awake as my coffee kicks in and I forget to hit the unmute button. I was also sharing that I'm very, very excited because we have a first-time case presenter, and anytime we have a new guest, this community it breathes light into the space. Ariane, I'll hand the mic to you to tell us a little bit about yourself.
Hi, I'm Arian from the Philippines. So I am Aaron's, a member of the team's classmate from med school, and I'm a first year resident in radiology here in the Philippines. So that's what I
Incredible.
do.
That's so cool. How did you decide to pursue radiology, Ariane?
Well, I've always been interested in not being in the
Yeah.
front lines. So, but I still want to be like clinically involved in the patient's care.
Yeah, 100%. So you want to do the correlate clinically yourself too, huh?
Yes.
That's amazing. You have a lot of fellow radiology lovers and maybe even people who are pursuing radiology. One of the first founding members of the academy, Ibrahim Omar, has near identical words about his career choice. He's a radiologist who loves to correlate clinically. I know there are many others here who have the same, including Sakith and Mohammed, who have a strong, strong passion for radiology, amongst others. So you're surrounded by people just like you in this space. I would also consider myself in that vein, increasingly so, as I realize that 95% of my diagnoses are made by radiologists, so I should probably get better at it. But we're very, very excited for your case. I think, Glenn, we probably have a reasonable chance of having to interpret some image. So I'm glad you have your glasses ready. Um, all right, Ariane, we're ready whenever you are. Take it away, please.
Okay, so for our case, this is a case of a 15-year-old female coming in for difficulty of breathing. So let's start with that.
Amazing. Thank you for that start. Yeah, Glenn, tell us what you're thinking.
Okay, so 15-year-old with a shortness of breath. So it's quite unusual for the young population to come with shortness of breath. So it means now the differentials that I normally know of shortness of breath, I have to change them a bit because of the age, 15-year-old female. So now um I would want to know more. Um, so what I'm thinking about right now is the heart and the lungs also, and also the neurological system as well. But because of the age, I would want to know whether this child has any congenital anomalies, um, and any family history of any hypercoagulable disorder which can lead to a PE. So uh, I think for me it's quite unusual for this presentation. So quite the normal causes of shortness of breath that kind of need to um prioritize some. And also I would want to know any history of trauma which can lead to shortness of breath as well. Any and also past medical history. Someone who has asthma, which is quite common in children, maybe it's coming with an exacerbation. Yeah, and then neurological causes I think are quite uncommon. I'm not sure if things like myasthenia gravis can cause this. And also another neurological cause I'm thinking is GBS. So I want to know if this patient had any recent illness and neurological deficits which can ascend and
Mhm.
cause difficulty breathing. So that's why I'm at the moment.
Yeah, I'm right there with you. I feel like, Glenn, if I was in a situation like this, I'd first of all be surprised. And I think I'd reason to be surprised is that the reason you said that is most of the time that people are short of breath, they have accumulated so much vulnerability from just being alive and developing atherosclerosis slowly, or potentially having exposures like tobacco that slowly destroy their lungs. And the shortness of breath that is happening right now is actually acute on chronic. So if you think about all the things that cause shortness of breath in older adults, congestive heart failure, acute coronary syndrome, pneumonia, COPD exacerbation, pulmonary embolism, all these things, when really viewed with a closed lens, have some chronicity to them. And the chronicity for heart failure is apparent. The chronicity for CAD is apparent. The chronicity for pneumonia is an age-related waning in the immunity most commonly. Um, and then the chronicity for pulmonary embolism is the same. The risk factor for PE, the cancer is developing over time. And then you see that these presentations are the tip of the iceberg. And so when you apply that same framework to a 15-year-old, you're asking yourself, gosh, what kinds of vulnerabilities can accumulate so quickly? And I think that the hidden lesson that I'm trying to impart upon somebody is most of the time when patients with shortness of breath, you will find an acute component, but you will also have to look for why did this acute component leave somebody so sick, and you often find a vulnerability. And I think the only common vulnerability in younger people is a vulnerability for atopic airways disease, asthma. And so this case will become routine, Glenn, if we hear that she has a history of asthma and that her features right now are consistent with an airways disorder, meaning that she is hyperventilating from an airways disease, as we reviewed in the academy recently. And if she doesn't have asthma, then we're doing a lot of work. And the work will be what is the acute component and what is the chronic vulnerability. And to keep that example more alive in your mind, when somebody who's an older adult comes in with a heart failure exacerbation, we have to ask what is the underlying cause of their heart failure and why today did it get worse? And so the same thing we have to do in this 15-year-old is what is her underlying predisposition and what is the trigger? That is the most productive framework for shortness of breath. Um, and in terms of the diagnoses you mentioned, I think they're all at play. The most common would be asthma. And if that's not at play, we probably have a lot of thinking to do for the remainder of this session. So, Ariane, Mike, to you. I'm curious how the story of this patient evolved.
Let's move on to the patient's history. So 4 days prior to presentation, the patient developed non-exertional shortness of breath associated with dyspnea and decreased appetite. These symptoms were not accompanied by chest pain or pressure, dizziness, fatigue, or peripheral edema. She did not seek medical evaluation at that time, hoping the symptoms would resolve spontaneously. And then over the following days, her symptoms gradually worsened with increasing fatigue. A few hours prior to presentation, she experienced an acute increase in dyspnea, along with new onset dysuria, and was noted to be lethargic, prompting presentation to the emergency department. And then upon further history, it was noted that 2 weeks prior, the patient reported a self-limited febrile episode, and then 1 week prior to presentation, she developed a diffuse rash, which improved with cetirizine and ambroxol. So, and she also noted yellow-green vaginal discharge beginning 1 week prior until presentation. Then for the past medical history, was unremarkable. Non-contributory family history and no known allergies to drugs or food. And the patient is also a lifelong non-smoker and denies alcohol use. However, she drinks at least 2 cans or bottles of carbonated energy drink per day. So that's our history.
Thank you, Ariane. You're laying out this very interesting story and showing us that there's 4 days of shortness of breath and decreased appetite. But there's also lethargy and dysuria happening now. But what's happening now isn't the only thing that's happening. In the recent past, she's had a self-limited febrile episode with a rash that sounds like she got anti-allergy treatment, if I'm not mistaken. And she also seemed to have some vaginal discharge. So, Glenn, I think it'd be probably very difficult to streamline your thinking into a clear path forward. But I'm really curious, what's happening in your mind, big picture? How are you jostling all these details and all this information?
Okay, so at the moment, the first thing I thought about was the dysuria. I wanted to connect it to, and then along the way, found out that there was also rash and also vaginal discharge. But before that, with the dysuria, um, so if it's and UTI maybe, which causes the dysuria, thinking maybe the patient um at the moment could be very sick, could be either wanting to know vitals from here to rule out any sepsis that could be going on, which can cause shortness of breath. Um, but also wanting to know more about any more of the urinary symptoms, like is there any blood in the urine? Thinking of those anchor vasculitis that can cause urinary symptoms and shortness of breath at the same time. But here also there's no history of uh, there's no blood in the sputum, so that would be unlikely. So I'll be thinking of an infectious cause that would explain the vaginal discharge, would explain the dysuria and the shortness of breath all at the same time. For the rash, thinking also maybe some post-rep glomerulonephritis could be going on, causing the dysuria. But then I would want to know how the rash was, and yeah, I want to know more information about how the rash was.
Yeah, I hear you saying you want to know a lot more information, and I'm right there with you. I think, Glenn, when I was a learner like you, a case like this would completely overwhelm me. And if I were to be honest about what this feels exactly like when I'm about to get a migraine. And when I'm about to get a migraine is usually when I'm sensory overloaded, when there's people, a lot of bright lights, a lot of bright sounds, a lot of people talking, and it's like I can't function and my mind collapses. And I think this is a case in real life that takes somebody and does that to them very easily. And I only have one piece of advice for you, Glenn. You are not obligated to explain everything. And I will go ahead and virtually guarantee you that you will not explain everything with a single diagnosis in this patient. Impossible. So the question is, how do you proceed forward? And I will remind everybody that you're only obligated to address the things you see. I can sit here right now and tell you that I have crushing substernal chest pain, apoplectic headache, and I have a hole in my nose. But if you don't see those things, you don't have to address them. And this is where what medicine is about. This is about training your eyes over time. But how do you train your eyes? You have to first use your ears, and you are listening to the patient's lived experience and mapping that on to your trained eyes to pick up those abnormalities. And I love how you started your reflection. You now know there is chaos in the history. And what you have to do is organize it with your eyes. Is there a rash now? Is there vaginal discharge now? Is there shortness of breath now? You have to use so for me, what is this case? It's actually quite simple. It's a 15-year-old woman who is here for unclear reasons. And I am about to use 15 years of examining people to help figure out what amongst the chaos in the history will I begin my analysis. And only the things that are happening before me are the things that I'm obligated to explain. If the rash is gone, good for it. If the rash is still there, I'm going to have to use it and get to the bottom of it. But if I cannot make progress with my eyes, then I will speculate on how a history of a rash could help me make progress. But if I don't need the rash, if I have diffuse alveolar hemorrhage and glomerulonephritis, I don't need the rash. And so eyes over ears, but all of you have been trained in medical school with your ears, listening to lectures over and over and over and over again. Thankfully, real life is not about your ears, it's about your eyes. And so I'm really curious what this patient looks like, and that'll help us organize our problem with much more clarity. And I find it very ironic that a radiologist is teaching us to use our eyes. Your livelihood depends on it, Ariane. So tell us more. What do you have next?
Let's move on to the vitals. So temperature is 36.9 Celsius. Heart rate is 136, BP 127/70, RR 32, and O2 sat is 99. Then on physical examination, the patient was awake but lethargic.
Ariane, sorry, can I just interject really
Oh, yes.
quickly? Do you, while you're, no, please keep going. You can remain unmuted. While you're presenting, do you mind just taking a look at the screen just to make sure the scribe is able to keep up with you? Because I think the pace might be just a touch too fast.
Okay.
Yeah.
Okay.
Do you want to just take it up start from the top again? And I think we'll grab all those vital signs one more time.
I'll put
Okay,
it in the chat also.
that sounds great. All right, go for it, my friend.
Okay. For some reason my screen is zoomed, but okay, I'll move on. So the patient is awake, lethargic, open eyes spontaneously with limited verbal response, producing incomprehensible sounds, and able to localize and obey simple commands. For HEENT, anicteric, pale conjunctiva without hemorrhage, dry lips and oral mucosa, no oral ulcers, trachea is midline, CV, tachycardic with regular rhythm, warm extremities, weak pulses, no peripheral edema. For pulmo, tachypneic, deep labored breathing, symmetric chest expansion, clear breath sounds, abdomen is non-distended, soft, and no grimacing on palpation. So for neuro PE, GCS12, E4V2M6, cranial nerve exam was limited by decreased verbal responsiveness, but no gross deficits appreciated. Strength grossly 5 out of 5 in all extremities, no involuntary movements, withdraws appropriately to painful stimuli in all extremities, no focal neurologic deficits, no seizures or decorticate decerebrate posturing. And then we move on to initial laboratories. So, okay, CBC, WBC is 31, neutrophils is 87, lymphocytes 11, hemoglobin 15.8, hematocrit 49 with platelets 514, BUN is 5.62, Rhea is 0.9, sodium is 132.5, potassium 4.36, chloride 95.9, and serum bicarb of 10. So let's stop there for discussion.
Amazing. Wow, this patient is really, really sick. Yeah, kudos to the scribing team for keeping up. Um, Ariane, may I ask, is the patient's glucose high or low, or do you have a sense of what the glucose is?
The glucose is actually high. I will be revealing the
Okay,
actual
I see. Okay, sounds
later.
good. Okay, yeah, that sounds great. Um, Glenn, I think if we try to stick to that original exercise of using our eyes first. So if you can try to, I imagine if I was in your shoes, I would be overwhelmed now. And I think the best strategy to remain calm in a moment like this is just to make a list of organs that you think are involved. So maybe we can just start with the physical exam alone and ignore the labs to try to practice real life. Because real life, you're going to have the labs after you analyze the exam. So what organs are you worried about based on the physical exam?
Okay, so first I'm worried about the lungs. So the respiratory rate is quite high and the saturating well, but I'm not sure if it's on room A or is this
Yes, on
saturating
room
well.
air. Yeah, on room
On
air.
room A.
Yeah,
Okay. Yeah, so I'm worried about the respiratory rate, but if it's saturating well, then I guess maybe the respiratory rate could be secondary to something else. Then I was reassured by the BPs that they're quite normal. I was thinking maybe the patient could be in shock, but the BPs are normal. The heart also is abnormal. Is the heart rate. So um there could be something else that could be explaining the heart rate. Maybe the there's a trigger to it. The temperature is normal, which I was thinking infectious cause could be causing this. But with the temperature now, infectious etiologies will be less likely. And then the cardiovascular system still there is weak pulses.
right.
So um, I'm thinking that the weak pulses and they want to know
Yeah,
uh, how come like the explanation for weak pulses and
yeah,
the the the, the heart rate being elevated.
good, good.
I think, and for the um pulm pulmonary
Yes,
exam, still tachypneic. So I'm thinking the way to organize this,
yes,
there could be something that explains both the heart rate and the
yeah,
respiratory rate.
good.
And infections would explain both of them, but now the
Yes,
temperature is normal.
right.
So I'm thinking of maybe a systemic problem that is
Very
uh,
good.
triggering reflex tachycardia and
Very good. Oh,
tachypnea. Yeah.
beautiful. Beautiful conclusion. Beautiful, Glenn. One final question, and then I'll reflect with you. What about her neuro status?
Oh, the neurologist, the patient has limited verbal response. I want to know
Yeah,
whether is it altered mental status or dysarthria is the patient.
yeah.
Um, yeah, I want to know the
But
whether it's the
I think it's
brain is involved
I
or
think
the
it's
the mind.
altered mental status because she is sleepy and she cannot. So she seems like she's like sleepy and cannot open her eyes. So I think it's altered mental status. How does that label influence your calculus? What do you think?
Yeah, so the patient is weak, also tachypnic, tachycardia at the same time. Um, I'm thinking more so still infectious cause.
Very good.
Uh, can, but then again, the temperature is does it involve
Yeah.
infection?
So Glenn, if I was with you, and I want all of you not to cheat, because if you are looking at these labs, you're cheating. Let's do all of us suffer with what Glenn had to suffer with. For 1 hour, you have a tachycardic patient with weak pulses who's tachypnic and who is altered before these labs come back. And the conclusions that Glenn came to are outstanding. And I think, Glenn, what you're saying is there's a heart problem, tachycardia. There's a lung problem, tachypnea. There's a brain problem, altered mental status. But to summarize what you said briefly, you are not yet convinced that these are the organs that are hosting this disease. And I think the case for the heart is the most compelling one because most of the time somebody has a tachycardia like this in the context of tachypnea and altered mental status, they have sinus tachycardia. And what sinus tachycardia is nothing wrong with the heart. The heart is doing exactly what it should in the face of a systemic trigger. So you looked at these vital signs, you said, no, the heart is doing a good job. Heart is not the problem, it is responding. You also did an outstanding job with something that a lot of people find harder, which is the lungs. This exam is the sinus tachycardia of the lungs. And I'm so glad we recently reviewed this topic in the Academy session that some people were there for. This is healthy breathing, deep and forceful. This is the lungs doing their version of sinus tachycardia. The lungs are healthy here. Just like the heart beating. So the lungs are not the host of this disease. Is the brain the host of this disease? Many people get altered mental status as a consequence of something outside the brain. That is especially true the older you are, but even more true when you have a systemic response. Most brain diseases can be managed safely by a neurologist alone without the input of a critical care or medical doctor. By virtue of this patient being so sick medically, there's only one or two neurological diagnoses that can live in the brain. And I'm really curious, Glenn, what would be your neurological emergencies for somebody this sick? What diagnoses are crossing your mind?
Um, so we maybe like a space occupying lesion.
Good.
Yeah,
Good.
but for it, I would expect the BP to be high,
Good. Good.
the heart
Good.
rate to be low. So,
So,
if
so a space occupying lesion in the parenchyma, anything in the meninges that can cause somebody who is young to become obtunded, confused, tachypnic, tachycardic in the meninges. What do you think?
yes, so just to carry on with the um my first thought of the infection, so maybe infection to the meningitis to explain the tachypnea and the tachycardia.
Exactly.
So,
Exactly. And I think you are looking for a fever, Glenn. The patient might be febrile in a few hours. A fever is a temporary up and down, up and down, up and down. But you don't need a fever because you now, with the labs, have a deep neutrophilia. That is more than a capable substitute for a fever. So I think your instinct about infection does not need to be eliminated based on the absence of a fever because fever comes and goes. So I think your instinct to worry about infection is strongly reinforced. But we have another abnormality, and that's the bicarb of 10. And I know that you've practiced this abnormality several times this week. So I'm really curious, how are you analyzing it in this case?
Yes, so back up of 10, I'll first want to rule out what I missed in that presentation. So I missed the case of a DKA, but that is was elevated anion gap metabolic acidosis. For this case, the chloride is 95. I think it could be a high anion gap since if it's normal anion gap, usually chloride is above, I think 100 or so. It's usually higher than that.
Mhm.
So uh, because of metabolic acidosis, high anion gap are used in mnemonic mud piles. So with the D in the middle, there being DKA. Other things you can think of uremia, which the patient has a normal uh, BUN. Where is it? The creatinine is normal here. And
Yes,
another thing, toxins. So ethynyl glycol, methanol, and then salicylates as well. Um, and then medications are some medication that the patient can cause others. So uh, I know of metformin and isoniazid can cause this. Yeah, so but for this case, since the patient is altered, I would think of DKA, but the patient doesn't have a history of diabetes. But then maybe it could be a first presentation of it. Uh, and also I want to screen for toxins as well, which can explain.
very. You don't need me, Glenn. I agree with you completely. I think uh, the urgent considerations in this moment, in this very moment, are: do we need insulin for DKA? Does this patient have a toxin like ethylene glycol causing altered mental status and acidosis? The neutrophilia is a separate issue that means we need to find the source of this likely infection in the next 1 hour. And the infection can be in the chest, in the abdomen, and if it's not, it's in the meninges. And so the question for you and me, if we're taking care of this patient, is how much do we rely on Ariane's radiology skills in the chest and the abdomen to diagnose an infection radiographically? Unfortunately, Ariane cannot help us diagnose meningitis. That is a diagnosis you and I have to make on our own. And so the difficulty in this case is how much do you invest in a radiographic diagnosis of a liver abscess, an empyema, pneumonia, cholecystitis, appendicitis? Or how much do you invest in a laboratory diagnosis of bacterial meningitis? That is the real life tension that the clinicians would feel. For me, I think we underdo lumbar punctures. I think that this patient would be not harmed by a lumbar puncture. And even if the LP is normal, we've made a lot of progress. So my threshold to do a lumbar puncture in a patient like this is exceptionally low. So yeah, a lot of work to be done, area, and I'll hand you the mic to enlighten us more. Thank you for this very, very interesting case.
I'll share screen. I'll just show. I'm not sure if you can see this, but can you see this?
Yes, we can. Yeah, we
This is
can.
the patient's chest X-ray. So there are no pulmonary parenchyma opacities.
Yes.
The chest, the heart is not enlarged. Diaphragm and costophrenic sulci are intact, and the visualized osseous structures are unremarkable. So basically, this is an unremarkable chest X-ray. So I'll stop sharing.
Wow. You even sound like a professional radiologist.
Thank you.
Oh, for sure.
So additional labs, we actually did an ABG for this patient. So pH is 6.92, PCO2 10, PO2 123, bicarb of 1.3, base excess of negative 31.2, and O2 sat of 95% on room air. So our anion gap is 35.3. And FBS was also done. The result is 582.56 milligrams per deciliter. So that's very high. So we'll stop there for discussion.
Ariane, I can't thank you enough for bringing this case because it teaches us so much, but also it showcases what we preach about all the time. Practice, practice, practice. Glenn and Manaswini discussed a case presented by our dear Shreya, who's doing teaching points, about a patient with very similar labs. And Glenn and Manaswini had growing to do in that discussion, and they grew from it. And now, the world is a beautiful place. Glenn is having the opportunity to grow even more upon that base. So, the being a great doctor is directly proportional to the amount of reps you get. And this is what people in the academy are doing so well, reps after reps after reps. So kudos to you, Glenn. Your hard work that day and your blood, sweat, and tears is paying dividends today. I'll hand you the mic, and I'm curious what lessons you learned from that day that you want to apply to this patient.
Thank you so much, Ravi. So after that rapid fire, the biggest takeaway was that always like check the glucose for someone with a low bicarb ultra status. So um, I was just thinking broadly of other causes of metabolic acidosis. Uh, but here in this case, the glucose is high, so it's most likely a DKA. And other ABG findings, I think I explained by the metabolic acidosis. I think the PCO2 of 10 would mean that the patient is hyperventilating. Like we saw in the exam, the high respiratory rate, and the P I get the bicarb also is low, and yeah, I think everything is explained by the iron and gap metabolic acidosis, and most likely to be DK because of the high glucose. So we want to know uh in any they check did they do the urinalysis to check any ketones in the urine. So I'm interested in that.
Very absolutely outstanding, Glenn. Since you have the whole DKA fully addressed, I will actually spend 3 minutes recapping. I wish we had recorded it and released it on YouTube, but we didn't, about this patient's breathing. If this patient came into many emergency room breathing like she did, she might have been intubated, and that can easily be averted, or at least an attempt to avert it can be done. And here's the approach to that. So whenever you have somebody who is who is breathing that fast, you want to ask, are they breathing that fast because they're obstructed, upper airway obstruction or lower airway obstruction? Or are they actually hyperventilating, meaning that they are breathing fast and effectively? And as Glenn mentioned, this person was breathing very effectively. How do we know? It was silent breathing, not loud. There was no wheezing, no stridor. It was deep and strong. This can happen for pathological reasons, namely an anxiety or panic attack, but nobody looking at this patient would ever think that. And the clue that we talked about was hyperverbality. Talking a lot and being anxious is very, very common when panic attack. And the patients usually, when they're having a physiological hyperventilation, are usually quiet. we had no hypoxemia here, and we have metabolic acidosis. And as we talked about, there is the possibility to fix this metabolic acidosis very, very quickly if it happens to be from ketones. Because if you, in this patient who is about to be intubated, get a point of care glucose that is 500, you should probably use rapid doses of IV insulin under the presumption that the patient has DKA. And IV insulin for ketosis can be a miracle drug. It can rapidly improve ketosis. It doesn't always, but it can rapidly improve ketosis and potentially give this patient a break from the enormous amount of work that she is doing to stay alive. Despite her breathing down her PaCO2 to almost single digit, her pH is still 6.9. So you really, really, if you're trying to be the best care of this vulnerable person, it is possible to correct her ketosis the moment she arrives because you see that she is breathing very effectively. You think, could she be having a panic attack or is she having a physiological response? The moment she's obtunded, you know it's not a pathological tachypnea, it's physiological to something else. What is that something else? Usually metabolic acidosis. And sometimes you can't fix the metabolic acidosis quickly. If it's ethylene glycol or lactate, it takes time. But there is one cause of a rapidly fixable metabolic acidosis, that is ketosis. Insulin is a miracle drug, and if used expeditiously, can potentially save the patient from intubation. Here, it might be too late because the pH is very, very low, but at least you give the person powerful chance. So, what's my ultimate takeaway for you all? You need a point of care glucose in all critically ill patients. You have been taught to get it for here, for strokes and seizures, and hopefully you've been taught to get it for abdominal emergencies because DKA presents with abdominal pain. And now hopefully you know to get it for emergencies here because severe tachypnea from DKA can also be treated with insulin. So everyone who is critically ill for any reason, point of care glucose, it'll help you here, here, and here. So we'll see what happened to this patient with a pH of 6.9. It might be just a touch too late to avoid intubation, but I saw that on the X-ray there was no ET2. So we'll see how this patient was managed. All right, Ariane, mic to you.
So we saw this patient at the ER. And then immediately the patient was hooked to PNSS 1 liter per one every hour. And she was managed as a case of DKA and placed on insulin drip of 100 units in 100 cc PNSS titrated accordingly. And then eventually, in a very, very short amount of time, her GCS improved to GCS 15, and then she was admitted to the ICU. So intubation was not done at the ER. And then eventually IVF was titrated, and then she was given 8 cycles of KCL, and then we became stable, eventually transferred to regular room and started on DM diet and lifestyle modifications. And then insulin drip was eventually discontinued, and then the patient was discharged stable.
Ariane, I just want to congratulate you and your team for avoiding intubation on this patient. It is a miracle, quite honestly. And I hope people are seeing that somebody coming in with a pH of 6.9, a respiratory rate of 32 can safely. And this is the only diagnosis I can think of where a patient avoids intubation. So really appreciate you clarifying that point. Now, I guess the question for us, Glenn, is sort of updating our problem representation and kind of plotting things going forward. So what is your current problem representation for this patient, and what are you thinking as next steps now that she's out of an acute crisis, you think?
Okay, so we had a 15-year-old female came with shortness of breath, who was tachypnic, the heart rate elevated, normal temperature, and that leukocytosis, neutrophilic predominance. had iron and gap metabolic acidosis and with elevated glucose and diagnosed with DKA. So going forward, I would um, just cancel for adherence on the glucose. Also, just on the diagnosis first,
Hmm.
because of the age also, usually diabetes associated with um, older patients. So just canceling on the patient about the diagnosis itself, and to take glucose regularly. So we want to do checkups for glucose monitoring, and also do monitor for complications after um, some time. So some years monitor for complications. Another thing which I wanted to also on counseling would be the previous symptoms that the patient had.
Hmm.
So I think now going back to the vaginal discharge, I think patients with diabetes tend to have um, candida infections
Hmm.
because of the high glucose means
Very good.
organisms can thrive in the urinary system. So counseling for that. And then another thing was the rash. Still don't have any explanation for the rash now.
I told you there wouldn't be.
Yeah, so that's what I would
Yeah.
talk about.
I think I'm so glad you went back to the chief concern. It goes to show you eyes over ears. Can you imagine if you just ignored the physical exam and just focused on the history? What would happen? You would be like, oh, maybe here's some steroid for your rash, and oh, here's some antibiotics for your UTI. In the meantime, the patient is about to be intubated for DKA, right? So you have to use the history to your advantage for sure, but all of medicine is all about training your eyes over time, and I congratulate you for that. Yeah, I think that there's one active question remaining for this patient's future, which is what kind of diabetes does she have? And based on her age and presentation of DKA, she very likely has type 1 diabetes, probabilistically speaking, which you might confirm with antibody testing and C-peptide testing. But the practical implications will mean that you cannot put her on oral hypoglycemics, that she needs insulin therapy, no matter what. The question for the moment is, what about her neutrophilia? And it's a reminder to always think about the five eyes of the triggers for DKA. She did not develop diabetes this week. She had the vulnerability of undiagnosed diabetes for some time. And the question is, what is the acute trigger? Infections, ischemia, inflammation, ingestions like steroids or cocaine, or initial diagnosis. We seem to have arrived on the fifth eye, initial diagnosis, but the deep neutrophilia mandates us to be thoughtful about whether she had an infection. Many people with a white count like this would get blindly covered with broad spectrum antibiotics. It doesn't matter now. The fact that she's better means our problems are solved, and it's just a matter of, in retrospect, was she infected or not? But I think the most important thing going forward is insulin therapy for a likely diagnosis of type 1 diabetes. Going backwards, it might be intellectual curiosity to see if she had an infection or whether her neutrophilia was just a marker of how stressed she was because she was literally gasping her last breaths as she was tachypnic and now confused. Ariane, I'm really curious. Did you all treat her with antibiotics? Did you find an infection? How are you grappling in the neutrophilia aspect?
Once at the ICU, they worked up for a possible UTI and was referred to OBGYN for the vaginal discharge. I
Hmm.
was told that she was given antibiotics for UTI. Unfortunately,
Yeah.
they did not update me about OBGYN facts.
No worries at all. Thank you so much. I'm really curious. What did you learn? What was your experience from this case?
Oh, take CBG. This was I was stationed at the ER during this
Yeah.
time. And then very shockingly a patient that's dyspneic and lethargic came in. So panic came in as I don't know what to do. And then I was like I immediately I took CBG, and then the initial labs assessed the patient very quickly, gave them fluids, and then I saw the elevated CBG. And so fluids, and then and that's what happened.
Yeah. Yeah, it's a very powerful reminder that what Glenn said, that tachycardia and tachypnea may mean that there's a problem in the heart or lungs, but it also means that it may mean that the lungs and the heart are responding very well to a problem somewhere else. And you can actually do this easily for the heart. You get an EKG, and if it shows ventricular tachycardia, the problem is in the heart. But if it shows sinus tachycardia, the problem is not. How do you do the same for the lungs? Your physical exam. If somebody is breathing like this, they have a blockage. They're forcing air out. But if somebody is breathing like this, they are breathing very well, just like somebody at the end of exercise. That is not a problem. So you can develop your skills, and your eyes can become an EKG. Is this effective ventilation or ineffective ventilation? And here, I think you showed us that the patient was beating effectively and breathing effectively, and the problem was very far away from the heart and lungs. Very powerful lesson. Thank you so much, Ariane. Anything, Glenn, that you want to emphasize before we hand the mic to Shreya for teaching points?
I know, like, I really learned a lot from this case. Just want to thank Ariana for presenting such a beautiful case.
Yeah, I couldn't agree more. Hopefully, Ariane, will see you much more often, presenting more cases. And I imagine you have many, many pictures to share with the learning community. But I really, really appreciate you coming on and presenting this case. And I'm so happy you presented a case of tachypnea with an X-ray that was clear and without an ET tube. Job very well done. All right, Shreya, mic to you, my friend. Take it away.
Oh, what a beautiful case, Ariane. Thank you for bringing this us, and please come back to us again. And what a terrific discussion, Glenn. So we had a 15-year-old female coming to us with a difficulty breathing. So whenever we have shortness of breath in a young female, we should always think of something that is acute on chronic. So the first thing we should think of is atopy, asthma, and we should also rule out other causes like congenital or autoimmune or vascular pathologies. So the basic rule is always try to figure out what's the underlying predisposition and what's the trigger that had pressure presenting to us now. And it's always different than adult, as we have to consider more life-threatening causes like ACS, PE. Also always think of possible retained tampon that can cause toxic shock syndrome in a young female. And whenever we have multiple complaints, we should always focus on present and most concerning complaint over all of the other complaints. So yeah, as Rabih said, eyes over ears. Whenever we have altered mental status patient coming to us, we should always figure out, is it brain? Is it something in brain, or is it brain through blood that is systemic involving other organs? So we should always think rule out meningitis or any space occupying lesions in the brain. On labs, we could see patient had high anion gap metabolic acidosis. So in a young patient having HAGMA, we should always think of any toxic ingestion like ethylene glycol or any possible decay diagnosis. Considering patients, not only considering patients' past medical history, but always thinking of possible decay presenting, always possibility of patient presenting with decay for the first time in an undiagnosed diabetic patient. We should always, and when we are considering decay, we should always think of finding source of infection what triggered decay at this point. So in this patient, we should have doing lumbar puncture threshold really, we should keep it really low. So patient had rapid breathing. As Rabi beautifully taught us that we should always consider, is it something obstructing lungs like asthma, anaphylaxis, or is it something that lung that is good in condition and it is hyperventilating secondary to compensating something like metabolic acidosis or ketosis. And if patient is uptended, we should always think of hyperventilation as the cause of rapid breathing. And if that's the case, we should always try giving insulin as early as possible to correct ketones for better outcome. And yeah, the diagnosis was new onset diabetes presenting as decay. And when we have a patient with decay, we should always consider triggers as 5 eyes, infection, ischemia, ingestion, or initial diagnosis. Thank you for this lovely hour with lots of teaching. It was a great case.
I find it perfect that you're doing the summary for DKA after you presented your case of a DKA with bucortia. It's a small world in many ways. Thank you so much for an excellent summary of the case. Big kudos to Noah for your awesome scribing skills, and Lana did a really, really outstanding job discussing. This was your second time, so I'm not the least bit surprised. It was remarkable as Ariane's first ever case presentation to be such a memorable one. So kudos to you all. Have a great rest of your day.